So allow me now to welcome Dr. Demiri, professor in Thessaloniki, who is going to talk to us how to select the best functional lymph nodes. Dr. Demiri, please.
Thank you. Just a moment, please. Allow me to, okay. So, dear Chairman, dear colleagues, dear attendants, can you hear me? Can you hear me?
Yes, we can hear.
Okay. Dear Chairman, dear colleagues, dear attendants, good afternoon from Thessaloniki, Greece. First of all, I would also like to thank the organizing committee of both our societies, the Hellenic Society for Reconstructive Microsurgery and the Hellenic Society for Surgery of the Hand and Upper Extremity, but especially my dear colleague, Dimitris Dionysio, who invited me to participate in this excellent panel with such an outstanding faculty. So, as we all know, and we already heard, the vascularized lymph node transfer is a well-established technique during the last almost 15 years now, since Corinne Becker first published her series and popularized this technique as the most logical approach for secondary lymphedema mainly, as it provides healthy vascularized lymph tissue and restores the lymphatic flow of the involved area. Since then, and during the last years, numerous studies have been published and have reported on the effectiveness of this technique, which, however, is not yet standardized, as we've already heard. There are many questions that need to be answered, like which is the best lymph node flap to transfer, how much tissue will we harvest, with or without skin, with or without lymphatic channels, how many lymph nodes are needed, how to select these lymph nodes, where to place them exactly, in which direction, etc., etc. And also complications, especially complications of the donor site, with a donor site lymphedema to be the most devastating complication that may occur. And this is the main reason for the criticism of this technique. Published reviews of donor site agree that there are some donor sites which are safer and are not related to iatrogenic lymphedema, like the omentum that we've already heard about, the supraclavicular donor site, the submental area. But however, even for the donor areas that are by far the most frequently used, such as the inguinal area and the lateral thoracic lymph node flaps, only a few cases of DSL have been reported, and although the percentages are quite small, they are still considerable. Moreover, most published studies are characterized by missing data. There are many details that are not reported, like the method that the authors use to select their lymph nodes flap preoperatively, or details on the technique that it is used for harvesting these flaps. So when trying to stay safe when selecting a lymph node flap, of course, anatomical data should be bear in mind, like, for example, the golden triangle in terms of using the inguinal area, which is the most frequently used worldwide, where we can stay safe within this triangle in order to avoid harvesting, avoid damaging the neighboring areas where the sentinel lymph nodes are most frequently located. Moreover, some functional studies have introduced new techniques like the reverse lymphatic mapping described by John Diane. We all know it. It is a technique that it is used by many centers in order to visualize intraoperatively which lymph nodes to avoid. In our department during the recent years, we have developed and described, together with our president, Dimitris Dionysio, a new technique, the selected lymph node technique, which is based on the findings of the SPECT-CT lymphoscintigraphy. As we all know, the SPECT-CT is a rotating gamma camera and a low-dose X-ray computed tomography in order to provide us accurate anatomical and functional information of the lymph nodes of the examining area. So SPECT-CT combines lymphoscintigraphy and CT images in a single gantry. When investigating an area with a SPECT CT, we can preoperatively visualize the lymph nodes of the area, and we select the best ones, namely the most functional, the most radioactive lymph nodes, which may be candidate for harvesting, and at the same time avoid damaging the nodes which drain the donor lymph. So what is the advantage of the CT investigation compared to the reverse lymphatic mapping is that the CT investigation shows us not only which nodes to avoid, like we can see here, but also which nodes to select. In our clinical practice, we use very many images of the SPECT CT in different planes, in a coronal plane, transverse, and sagittal plane, in order to analyze the exact location of our selected lymph nodes. So we can measure the distance of those lymph nodes from some anatomical landmarks like the median line, the anterior superior line, the symphysis, or the skin level, like we see here. And we can transfer these measurements on the skin of our patient, and that's how we know exactly where our lymph nodes are located. And we know exactly intraoperatively where to find these lymph nodes, which are the most functional and the most safe. In terms of selecting the nourishing vessels for our lymph nodes in the setting of inguinal lymph node flap, we may select the CIA vessels or the CIEA vessels depending on intraoperative findings, depending on their size or their relation, how close they are to our selected lymph node flap. And these nourishing vessels are harvested with the flap. And this is how our selected lymph node flap looks like after cutting our pedicle and before transferring the flap to the recipient side, which is, in this case, it was a breast cancer case. It was the axilla, as we see, after, of course, complete axillary scar release, which is also mandatory. Here we can see one of our cases, a breast cancer case with a stage 2 left arm lymphedema after radiotherapy and lymph node clearance. Here is the SPECT CT image where we can select our most functional lymph nodes. Here is the drawing of the lymph nodes on the skin of the patient. We can see them where exactly they are above the inguinal ligament. And here is the result at 12 months. We can also combine this selected lymph node flap to a pre-designed abdominal DIEP flap in cases where we want to simultaneously reconstruct the breast and the lymphedema in mastectomy lymphedema cases, like in this case, with the stage 1 lymphedema of the upper limb in this mastectomy case. Here we can see the selected lymph nodes with the preoperative design of the lymph nodes and our abdominal flap. Here is our combined flap with a lymph node component and 2 pedicles, because we routinely perform 2 pairs of anastomosis. And here is our final result with a breast reconstruction and also an important reduction of the volume of the operated limb. Here we can see the distribution of our selected lymph nodes in our series of 41 published breast cancer lymphedema patients, where all our lymph nodes were included in the golden triangle above the muscle fascia in a superficial level, and always avoiding the deeper planes and the sentinel lymph nodes of the donor limb. This technique may be used also to pre-select the lymph nodes of the lateral thoracic area, which is frequently used to manage the lower limb lymphedema, like in this case, a secondary lymphedema after hysterectomy and radiotherapy. Here are the pre-selected lateral thoracic nodes with a drawing on the skin of the patient, the preparation of our lymph node flap, and the final result at 1 year with a very significant reduction of the volume of the affected limb. What is also very important is to assess our outcome, assess the effectiveness of this technique by assessing both the lymphatic flow of the donor site and also documenting of the lymphedema improvement and also the viability and function of our transferred lymph nodes. So in a series of 41 lymphedema breast cancer patients who were treated by an inguinal cell lymph labs, we assessed the donor site at 12 months. In those patients, all patients in ICG lymphography had normal pattern of lymphatic vessels on both legs. No patient had any clinical evidence of donor site lymphedema, while in 15 patients who accepted to be reevaluated with lymphoscintigraphy, no significant alterations of the lymphatic circulation of the donor lymph was recorded. Moreover, the mean volume reduction of the affected lymph was recorded to 53%. In another series of 2 lymphedema patients with secondary lymphedema of the upper or lower limb that were treated with selected lymph node flaps, we assessed their lymph nodes at 12 months. 19 patients accepted to be reevaluated with a lymphoscintigraphy. Of those 19 patients, 15 showed improvement of the lymphoscintigraphy findings. 9 of those had visual lymph nodes in the lymphoscintigraphy, while another 6 had a decrease of the dermal backflow, while only 4 had no change on their lymphoscintigraphy findings, while all patients had clinical improvement of the affected, the operated lymph, and also no clinical evidence of the donor site lymphedema. I would like to conclude my talk with a famous Hippocrates phrase, first, do not harm. It is very important when performing such procedures, a VLNT procedure, to use a meticulous surgical technique, but it is also mandatory to preoperatively evaluate the patient and analyze the lymphatic status of the donor site, which has been selected to be used in order to select safely the best, the most functional lymph nodes. In our hands, the SPECT-CT guided celling technique, which is, to our knowledge, the first method for preoperative selection of the most functional lymph nodes, at least for secondary lymphedema cases, works very well. And it has been proven a very helpful tool in terms of minimizing complications, the DSL, while we can select the most safe lymph nodes, and also optimizing our outcomes because we select the most functional lymph nodes. All these messages are included in the word THALASSA, which is a newly introduced acronym for the Thessaloniki algorithm for lymphatic analysis and safe surgical approach. Thank you very much for your attention.
Thank you, Debbie. Great. So it was an excellent presentation. It was our work, and we are proud to announce Thalassa, which is beautiful name in Greek.
Yes.
It means summer, and it means beautiful sea, sunny places. So we hope next time to see you all in Greece and to enjoy the Thalassa with us. So thank you, Debbie.